Hey, we're almost done. Let's talk just a little bit more about tolerance and overdose. One of the things that we know is that generally, because you have to take a larger dose to produce that high, because your body is reducing its number of receptors and your liver is becoming better at breaking it down, you're going to have to take more to produce that high. And if we're talking about something like heroin, remember that it has a pretty low margin of safety. What this means is that even though you're taking more of the drug to get the desired effect, you are also increasing the likelihood that you overdose and develop respiratory suppression. So one of the things that we actually have to potentially treat that, if you do have respiratory suppression, is you will develop something like naloxone, which is actually derived from opioids. It is sold over the counter as Narcan. You might have actually heard a little bit about it. Basically, this is directly injected into the body, and it displaces and acts as a receptor antagonist, basically dislodging opioid molecules from binding with those receptors. So naloxone is something that can be used. Additionally, we do know that with respect, there are a lot of different opiate receptors in the locus coeruleus. So what this means is that it can also affect norepinephrine production. In particular, we know that because of its effects on the brainstem, it actually inhibits both production of norepinephrine and acetylcholine. So one of the things that we will actually find is that there will be reduced sweating, reduced sympathetic nervous system activity, digestion, reduced heart rate. Something else that it actually also produces, if you want to see if somebody has overdosed from an opioid, check their pupils. If their pupils are constricted, they have probably overdosed on opioids. That's one way that you can actually tell. Now, if an addict stops taking opiates, about 24 hours later or less, they will start to feel withdrawal symptoms. And that's generally going to be the opposite of the effects of the drug. So because opioids are largely depressants, they inhibit this system, you're going to see a lot of things start speeding up. If locus coeruleus activity increases, you're going to get a lot of norepinephrine production. So you're going to get a rapid heart rate increase, potential heart attack. Suddenly, the locus coeruleus and all of the other regions that were receiving opiate input are basically going to rebound. So the withdrawal effects can be pretty serious. Physical symptoms of withdrawal are often described like having a bad flu. You will typically have aches, pains, sweating, vomiting, diarrhea, nausea, upset stomach, anxiety, and withdrawal symptoms will typically be the opposite of those drugs. Life-threatening withdrawal symptoms for these, if you take depressants, and similar findings happen with alcohol, are increased heart rate and blood pressure. People rarely, but it does happen, they can actually die from a cardiovascular complication related to withdrawal. There are cravings, anxiety, and insomnia. Generally, the physical withdrawal symptoms pass in a few days, but the psychological symptoms can go on for a while. And it's usually the psychological withdrawal that actually causes somebody to return. Generally, the chemical that's used for recovery from opioid addiction is a synthetic agonist known as methadone. It's typically used to replace morphine or heroin so that the needs of the body and the mind are met. But methadone doesn't really produce a lot of craving, and this allows somebody to engage with the world and kind of withdraw safely. It's actually pretty complicated and controversial. Some people will actually say that the addicts are still addicted. They just are now addicted to methadone instead. There is a physical dependence to methadone, but you don't typically get cravings with methadone. There's a lot of data that speak to the success of these kind of opioid replacement programs. It's typically administered with a juice. They have to get monitored, so they don't take these alone. Somebody administers the pills to them, because sometimes if you get your hands on methadone and you get a lot of them and you crush them, you can get high off of that. We don't want people doing that. So people will typically go to a clinic once a day to get their pill and take it that way. And they're tapered off slowly so that they don't produce withdrawal symptoms. And generally, any withdrawal symptoms will tend to be a lot less painful or difficult compared to something like heroin. So we will come back in a little bit. I will talk a little bit about some of our stimulants like cocaine, methamphetamine, and ephedrine.